So good morning, everybody. I'm very pleased today to introduce our speaker. It's Dr. Chris Sweeney. He comes to us from the Dana-Farber Cancer Institute in Boston. And he did his medical training in Australia and went on to do his residency training in Indiana. Subsequently, he was appointed Associate Director to Clinical Research at the Simon Cancer Center there. He then went on to join the Lank Center for Genitourinary Oncology at Dana-Farber and Harvard Medical School in 2009. His primary research interests are in drug discovery and development. His academic focus is primarily in prostate cancer and testicular cancer, and he's going to talk to us today about a very exciting trial that was presented in the last year or so in prostate cancer. Thank you.
Thanks, Carla. It's a great honour to be here, and just walking around, you can see it's one of the greatest medical precincts for cancer and biomedical research in the world. So to come and present in this wonderful audience, to this wonderful audience in this wonderful location is a huge honour, so thank you. This is a legitimate question. Chemo-hormonal therapy in prostate cancer, why was it positive? So for this complete disclosure, I do consultancy with compensation for a number of companies. So let's be honest. Few, if anyone, thought the Charter trial, which was chemo-hormonal therapy, docetaxel plus androgen deprivation therapy versus androgen deprivation therapy alone, would impart a survival benefit in M1 hormone-sensitive prostate cancer. Or at least it felt like that for 10 years when everyone was telling me, this is boring, this is going to be negative, why are you doing it? And also, the other thing we should be honest about, people would rather we saw the benefit and could use a non-cytotoxic in the place of docetaxel. But is there a reason why horizontal targeting of different biologies rather than vertical targeting of the androgen receptor would be beneficial? These are two conversations I'd like to bring up through this talk. So full disclosure, I do not know why chemo-hormonal therapy was beneficial in prostate cancer. The title of the talk was a real question. At most, I can offer some speculative thoughts, so please don't leave. I've locked the doors already. So the roadmap for what we're going to talk about, by we I mean me, metastatic hormone-sensitive prostate cancer in context, what's the history of it, how have we been managing it for 70 years, the E3805 trial, the Charter trial that was presented at ASCO and which was just recently published this year, an ECOG-run cooperative group study, considerations as to why Charter showed a survival benefit, maybe, what the possible reasons were. This study, in the light of a negative French study and a recently presented prostate cancer study done by the MRC, called the Stampede study. I'm presuming some people don't know these studies because there's breast people, there's GI people, and so I'm not presuming people know this completely. Then I'll go into the speculation as to why it was possibly beneficial in prostate cancer and how it possibly could translate or be relevant to the negative breast cancer studies. So metastatic hormone-sensitive prostate cancer. So if you think about it, and actually there's just a wonderful, when you delay at the airport, you actually get to read some of the New England Journal come up on your phone. And there's a wonderful article done by the Connecticut folk just talking about the systemic nature of breast cancer and the possible difference between breast cancer and how the rates have been steady for many years, whereas prostate cancer, the rates and the death rates have declined over time since PSA screening per Albertson and their team. And it talks about, and I think this actually describes this a little bit, some of prostate cancers are just slow growing and you can catch them early. Do they need to be treated is sometimes a question. Some of them do, some of them don't. But even despite heavy PSA screening, both in Canada and the United States, the death rate from prostate cancer isn't that much less than a country that doesn't have much PSA screening, such as Colombia. So here's doing the numbers. In the United States, there were 29,000 deaths in 2014 out of 230,000 cases. About 95% are localized disease, and most, 200,000, get localized therapy. And when we looked at the SEER database, about 8% of the 200,000 patients die after localized therapy. So that's about 17,000 of the 29,000 deaths. But then there's this other phenomenon, which has been vastly ignored because they've been in the county hospitals, they've been in the VA hospitals, And we've been diluted by all these low-risk prostate, and they've filled up the prostate cancer clinics, and we have forgotten about this entity of de novo metastatic disease, which is about 5% in a heavily screened country called the United States, which is about 10,000 deaths, with a median overall survival of 3 years. Speaking to a different biology to the slow-growing progressive cancers. So there are 3 ways, unfortunately, to death from metastatic prostate cancer. Most patients present with localized disease, most are cured or didn't need therapy. A few escape and develop metastatic disease. And then there's the other entity that presents with metastatic disease. And then there's this approximate 30,000 deaths. And then we have all our treatments, all these novel, fantastic, expensive treatments, non-cytotoxic and cytotoxics, have been developed in the castration-resistant space. So what is the cause of the death rate from prostate cancer? And it's been argued it's early identification with PSA screening, combined with the use of adjuvant androgen deprivation therapy, especially for the high-grade, high-volume diseases, and Poldrick and the team, the NCRC and MRC, showed that when you did hormones plus radiation, you do better than hormones alone. So combined integrated therapy has decreased the death rate. And these 2 things probably do account together for the decreased death rate from prostate cancer in the United States by about 30%. This is also true in other diseases. BEP chemotherapy for germ cell tumours, ABVD for Hodgkin's, etc. Radiation plus chemotherapy for head and neck. Surgery plus chemotherapy for breast cancer and colon cancer. And hormonal therapy plus local therapy for breast and prostate cancer. I hope I've toned it up to everyone in everyone's disease centre in the room here. I'm trying to not make this GU specific. But the principles and the premises that led to these successful strategies are 3 very simple premises: single-agent anti-cancer activity, non-overlapping toxicity, and different mechanisms of action. And this even plays into lung cancer, for Dr. Shepherd's sake. I didn't have lung. Yeah. So for not locally advanced disease, surgery plus chemotherapy decreased the death rate. I forgot that.
Thank you.
So integrated therapies work and do cure patients. But we should use these therapies when the tumour has a lower tumour bulk, because this leads to more cures, and we should focus on micrometastatic disease or disease that is more sensitive. Well, what have we been doing for the last 70 years, coming up on 80? Well, in the 1940s, testosterone suppression, and basically that was it. You get castration-resistant disease, and then we'll maybe find some therapies. And we start off with mitoxantrone by someone else in the room here, and then Ian have showed that you can maybe feel a bit better but don't live longer, and then we have probably more than $1 billion worth of drug development in the castration-resistant space. And the first one horse out of the gates was docetaxel. The other thing we've known over the last 70 years is that if the higher burden of disease, the less likely you are to, the shorter your survival is. That is basically 70 years of studies and research into hormone-sensitive metastatic prostate cancer in one slide. So this was the premise for why we would do chemotherapy, in this case docetaxel, active in castration-resistant disease, plus hormonal therapy. 1, let's go after the de novo androgen-independent cells early. The other reason why it might work is that sometimes it could be a long time frame, and a patient may be suitable for chemotherapy at the beginning of their metastatic disease, but not when they progress. On the other hand, hormonal therapy might take the cells out of cycle, and they would be less responsive to cytotoxics. And some patients respond for a long time and never need chemotherapy. So you don't need to do the study because it's going to be negative. Well, I would say we needed to do the study because these two are the 2 reasons need to be addressed. The other thing that people question is why did we break up patients with high volume and low volume disease? And the answer is because those who have high volume disease do poorer, and the ED in the charted study stands for extensive disease, because when we started the study, we actually did only allow patients to be accrued who had high volume disease, thinking they had the most unmet need, and they're the ones the urologists were more likely to refer to us to give them this noxic thing called chemotherapy. Their mindset. So we were basically playing to the audience of who would be the referrers. So here we can see a SWOG study started in the 1980s. basically the bottom curve is if you have extensive disease defined as liver metastases, lung or liver metastases, or at least one lesion beyond the axial skeleton. Clearly a much poorer survival with a 27-month median overall survival. The MD Anderson had a similar definition, a similar outcome when they did their study, and their definition of low burden of disease was 3 or more bony metastases. High volume was 3 or more bony metastases or the presence of visceral metastases with a median survival of 3 years. So we can basically identify patients with a median survival of about 3 years versus those who have a median survival of about 7 years by looking at the disease distribution. So our definition in the E3005 caused quite a bit of stir. The reason we did it was because we wanted to avoid misclassification. Because in the SWOG definition, if you had an isolated rib metastasis, that's oligometastatic disease, but you would have been, and do very well, but you would have been included in the high volume in the SWOG definition. And we also wanted to avoid a couple of fuzzy spots in a bone scan being called metastatic disease when it could have been degenerative changes. So we basically wanted to annotate the disease burden by saying if you had one beyond the axial skeleton, it probably meant what was in the vertebral bodies is probably real. So that was the thinking behind this somewhat convoluted definition. But it turns to, when we looked at this and compared the outcomes of different cohorts, we found that this definition did seem to have a hazard ratio of about 2-fold greater chance of dying of prostate cancer whether you had high volume versus low volume, and be very consistent across many data sets over the years. So I will not go into the Charter trial in detail, but I'll just hit some highlights. Why did we do it? Because we were going after the premises of different mechanisms of action, single agent activity, and non-overlapping toxicity. And hopefully by doing the two things together, patients would live longer when treating hormone-naive metastatic prostate cancer. It was a simple design, because really I'm a simple person, I'm not that convoluted. I couldn't possibly ever put together a Stampede study, which is a brilliant study, but I just wouldn't be able to do it, I don't think. So hormonal therapy plus docetaxel, 75 milligrams per meter squared, stop the 6 cycles, done, just continue the hormonal therapy, and Arm B was hormonal therapy alone. At progression, the therapy that was given was at investigator discretion. What the patient and the physician thought would be the therapy that was most appropriate for them. So it was a real-world therapy instead of mandating docetaxel at progression, because things change over time. And we stratified as best we can to make sure the groups were even for extent of disease, age, performance status, use of combined androgen blockade, use of agents like zoledronic acid or denosumab, and prior adjuvant therapy. We did allow a window of opportunity for hormonal therapy to allow patients to get from the urologist to the hormonal therapy to the enrollment study to get chemotherapy. We didn't allow intermittent ADT, gave standard dexamethasone pre-medication, and as Ian and I have talked about, the only reason you put prednisone in is if you just wanted to follow on from a history of prednisone versus mitopred versus docetaxel pred's the standard. Well, pred was just basically a carryover from the FDA, but in this case, we actually have another really good hormonal therapy instead of prednisone called the androgen deprivation therapy. So we said no to the prednisone. You're probably going to add toxicity in terms of poor metabolic health. So we did not require daily prednisone. What were the inclusion criteria? Basically, metastatic prostate cancer, limited amount of hormonal therapy, reasonable organ function to get docetaxel, and no prior docetaxel. So the bottom line is a chemotherapy patient with metastatic hormone-sensitive prostate cancer. Overall survival. Why did we use overall survival? There's this whole big effort to use radiographic progression-free survival. Well, when you're using a cytotoxic, you have to have not a fuzzy endpoint, but a real endpoint. And to convince people to believe the study's real, even if you do have an overall survival benefit, still doesn't convince people, it turns out, all the time. That was a nod to Ian. And we'll get to that. So secondary endpoints, annotating PSAs less than 0.2 at 6 and 12 months, time to radiographic PSA rise and radiographic progression, adverse event profile, and quality of life. Spoiler alert, this will be presented at GU ASCO, and despite getting a Noxus agent, you do have a better quality of life in the long run. See you at GU ASCO. Someone else is presenting that data. Who were the patients who ended up in the study? Had a median age of 60, so a little bit younger, which speaks to this patient population were those who had were chemo fit. Brackets, just looking at the study of Enzamet, which we're doing, which was ADT plus or minus enzalutamide, and you get stratified by whether you get docetaxel. The median age on that so far is 70. So there is actually physician selection bias as to who went on this based on that fact, but also it is the chemo fitness which is driving this, I think. Most of the patients were white and had a good performance status. Basically 100% had performance status 0 or 1. Most of the patients had high volume disease, 2/3 of the patients. So the physicians who referred the patients, namely the urologist and the medical oncologist, said, we know this hormonal therapy is not going to work, let's actually support the trial, although it did take 8 years to accrue. Most of the patients had high-grade disease, as one would expect for a metastatic population, and the median PSA at the time of ADT start was 50. Another interesting fact is that most of the patients who end up on a metastatic hormone-sensitive study have had no prior localized therapy, and so presumably most of these patients are those who have de novo metastatic high-volume disease. And that comes into thinking about who are the patients who do benefit from this. Also, the median time from ADT start to randomization was 1 month. So it turns out that urologists and medical oncologists and clinical trialists can get along, and patients can get on this study pretty quickly. So here's the overall survival. Yes, when I saw these, I actually did 1, look at them twice, then 2, cried, thinking, oh my God, this is positive. And what does positive mean? There was an increase in the median survival from 44 months to 57 months, with the hazard ratio being 0.61, namely a 39% greater decreased chance of death at 24, 36, 48, and 60 months. Some people would say, well, this actually looks unbelievable compared with the other studies, but let's get to that later. And then when we break it out by high volume versus low volume, you can see actually that the high volume, the patients who have most of the events, drove the overall survival benefit at this early analysis. This was positive at an interim analysis after the study was completely accrued. And because we see that the median survival is 32 months in the hormones alone and 49 months. And just to pause and think about how well the control arm functioned, we actually projected a median overall survival of 33 months, having worked with Kathy Tangen and the SWOG group, and applying our definition to the previous study done by the Southwest Oncology group of the continuous arm of the intermittent versus continuous hormonal therapy in metastatic disease. And basically, they said 33 months. And if you add 32 plus 1 month, the median time to ADT start, to the randomization, it's 33 months as well. So it's bang on the same number. So the control arm for high volume functioned as we expected, and the control arm for the low volume did as well as we expected with less events, but people do take note that the hazard ratio is still 0.6 here, but it's not statistically significant because there haven't been enough events and we need longer follow-up, as you can see here. And why was there a benefit? Because when we look at the causes of death, there was less deaths from prostate cancer, 84 versus 102 deaths. And when we look at the forest plot, everything is to the left, really saying it wasn't driven by one group or another. The only ones that cross the 1.0 are those where we had less numbers in each group. We don't make too much of subgroups, but interestingly enough, even the elderly patients still had a benefit. We're actually looking into the race issue. Asian, African American and Hispanic, small numbers, but we'll look at how they do. Low versus high volume, types of metastasis, whether it was visceral metastasis that got you high volume, or high volume because of the bone burden. Gleason score, prior localized therapy. So everyone seemed to benefit. To annotate that decreased death, we actually also saw greater PSA control at 6 and 12 months, with doubling the number of patients who achieved a PSA of less than 0.2. And the median time to PSA rise was 14 months versus 20 months. And the median time to clinical progression increased from 19 to 32 months when you got the early chemotherapy. and this may explain the quality of life benefits with the combination. This table actually differs to what's in the New England Journal paper because we did a snapshot in January 2014 for the public presentation, and this was the number of therapies at the time of the overall survival analysis. And as you can see here, 174 patients in the early ADT alone had progressed, and 129 of them had got chemotherapy. So about 75% of those who progressed actually had docetaxel at progression at some point. They also got cabazitaxel and a reasonable amount of abiraterone or enzalutamide. So those who were on the ADT alone did get quite an amount of therapy for castration-resistant disease. It wasn't as though they didn't get therapy. How well was it tolerated? Well, when you look at the toxicity analysis, a smattering of grade 3 of the usual toxicities, colitis, diarrhea, and motor and sensory neuropathy, and there were some hematologic toxicities. And basically, in this study, in a chemo-fit, well-selected patient population with eligibility criteria, Ian's point, the number of patients who ended up in the hospital with an infection was 8%. So there was a 1 in 12 chance between febrile neutropenia and infection with neutropenia. And I do agree with Ian that these chemotherapy studies do differ to what happens in the real world, and we do need to be cautious, and we still have to think about chemo fitness. But in this study, it was 8% incidence of bone marrow suppression with some sort of infection. So our conclusion back in 2014 is that the combination of 6 cycles of ADT, standard ADT and 6 cycles of docetaxel significantly improved overall survival compared with standard ADT alone in men with hormone-sensitive prostate cancer. So this is the statistical conclusion. But then we have the patient in front of us and we have to make clinical decisions with this information. And we said last year, the benefit in patients with a high volume of metastatic disease is clear and justifies the treatment burden, but they need to be chemo fit, and longer follow-up is to see if there's a benefit with low volume metastatic disease. So let's think about why the Charter study showed a survival benefit for early chemo-hormonal therapy. This actually brings us to the two conversations we're having in cancer research and clinical oncology: tumor heterogeneity and precision medicine. And these two juxtaposed thoughts are actually completely contradictory, I think. So how do we reconcile these two opposing thoughts? But by the way, what is precision medicine? Bit of audience participation?
Mary thinks it's radiation.
Especially with the SBRT bit to it. So precision medicine, it sounds really good. Our president loves it, the press love it, the people love it, and then there's the reality. So actually, this is a snapshot from the internet, from the White House website. They're in on it. So who agrees with the definition that precision medicine is right drug at the right dose for the right tumour at the right time? Who thinks that's the definition of precision medicine?
Not so bad.
Yeah, it's not so bad.
It's not so bad. Yeah, it sounds about right. It's a definition. You don't have to say it's going to cure cancer. Who believes this approach will eradicate cancer? Who doesn't think this approach will eradicate cancer? Canadians are very pragmatic, eh? So there's been this talk about the war on cancer since the 1970s. I actually want to just take a moment and say, actually there's been a war on cancer since ever cancer has been around, but we can use the analogy as we go back. The University of Chicago, Huggins and Hodgins, discovered that testosterone drove prostate cancer. You take away testosterone, cancers regress, both in dogs and men. Interestingly enough, the Manhattan Project was also happening at the University of Chicago. Development of the atomic bomb and all this sort of business. What was the opportunity that was lost? If only the normal human volunteers for the testosterone suppression was actually the warmongers, we might have world peace. But what is interesting is that the clinical observation led to discovery of the androgen receptor, and that's a good thing. Then we had the war on cancer, 1970s, the Nixon decree, And then we had the approach of carpet bombing with cytotoxics. The Emperor of All Maladies, if you haven't read it, is a great read, just putting this all into context. And then the drone strikes, precision for a given target. This is the Obama era. But how often are the targets present? And sometimes we go after them and they're actually not the right targets, and then we have disasters in Afghanistan. And so the analogies actually really do hold up when we're thinking about the patient in front of us. We still have non-heme toxicity, friendly casualties, and we have had precision medicine for 70 years after going after the androgen receptor. And I propose we've got to think about diseases as multi-genetic disorders versus oligogenetic cancers. Non-small cell lung cancer, castration-resistant prostate cancer, and pancreatic versus CML, GIST, and subsets of non-small cell lung cancer. And I would propose that horizontal inhibition has cured more cancers, especially those with multi-genetic disorders. And then there's this entity going on in the world on the east and west coast, and because it's America, we give it some fantastic names. I can say that with an Australian accent and pull out my Australian passport. When I talk to them, I pull out my American one. Yeah, it's a great idea. Called Dream Teams. It's like it's inspirational, isn't it? So what has been done is biopsying men with castration-resistant disease, and what they've been found is that there is clonal evolution of prostate cancer, and sets of mutations in castration-resistant disease has been noted, and most of it's around the androgen receptor. And there's a great story that was just in the online version of the New England Journal yesterday about Johan de Banu and the team's work at MRC talking about DNA damage repair genes, which actually has come out of this work with the Stand Up to Cancer, which is all Hollywood philanthropy, by the way, but they're actually doing something with it and finding some interesting. So we've talked about this. This is the integrated therapies that I mentioned earlier. So tumour heterogeneity in prostate cancer is more than 50 shades of grey. Here we have a patient on the left who has one isolated pelvic bone metastasis and another man who rolls in with extensive disease. Have not and will not read the book or see the movie, to be clear. But Anthony tells me it's fantastic. So, anecdotal experiences of the extremes of prostate cancer, hormone sensitive. A 48-year-old man presents with a PSA of 57, having trouble peeing, sees his doctor because of that, and has this as his baseline imaging. And 12 months later, less than 12 months later, he has this, after extensive liver replacement, which was AR negative, chromogranin negative, didn't respond to platinum, and unfortunately passed away. On the other hand, this gentleman, low volume disease, 67, gets randomized to ADT plus docetaxel, PSA of 0.02, almost 4 years after he enrolled on the study. Quality of life is excellent. He sends me this photo, and I reply back, look, I'm worried about the competing risk for mortality of those on the low volume. Can you be careful as you're doing your indoor climbing? But here are some... this is a nuclear medicine physician at Sunnybrook who was at Brigham and Dana-Farber for a while, Catherine Sukotiniski, and we did this study of abiraterone-covered xanthine. We were able to do some PET imaging. Left is sodium fluoride, right is for FDG, and as you can see, there's far more sodium fluoride disease, avid disease, but only one of the lesions actually was FDG avid. So it speaks with intra-patient heterogeneity. And then this is actually some very, very intricate nuclear medicine lingo that I can't read. But what it is the blue curve are patients who had minimal FDG uptake. The yellow one are those who had one isolated lesion with FDG avidity, and the green are the two patients out of we studied who had a high disease burden with FDG avidity. And bottom line is, if in this small study, just pilot look and see what's happened, you don't actually respond well to hormonal therapies, even if you have cabozantinib with it, if you have FDG avid disease. So, this isn't because Ian's in the room, it's because I actually believe this. Is the benefit in the high volume due to just a matter of high volume patients have more events sooner and early chemotherapy has an effect sooner? I think that's true. Patients with low volume disease have less clonal level evolution and more AR dependent and just need ADT alone. I would say that may be true. Some patients may do well with hormonal therapy alone and don't need the chemotherapy. But I think the answer is both 1 and 2 are at play, and we need to think before we shoot when we give chemotherapy to some of these patients. So this is what I think we're doing. Hormonal therapy, we have regression of the white cells. The red ones still stay. You get regression, and then there's reemergence of this polyclonal disease called castration-resistant disease. Hormonal therapy plus docetaxel, you get regression of both the red and the white cells and delayed emergence of this polyclonal disease called castration-resistant disease. Out of propriety, and depending on the audience, you don't make those, refer to these things as balls, and you don't make the red ones blue balls, because no one likes the blue balls. Or at least reference to it. It works in a urology audience, I'm not sure, but... and you've got to play to your audience. But I thought this is Canadian, a lot more fun. So possible explanations and hypotheses is where I want to move into now. Chemotherapy debulks the AR-negative disease, allowing the second-line AR-targeted therapies to be more effective. And let's actually put this into context of the other studies. So basically, the accountant of the Charter study was this study done by the French, led by a wonderful lady called Gwenelle Gravis, and the GTUG team, hormonal therapy plus chemotherapy. Their study was really negative. Ours was really positive. So it is a tale of two trials. If only this one was London and that one was Paris, it would actually be a Victor Hugo, but... But actually, people said, well, the two studies are different. The study populations are different. Actually, when they did longer follow-up and actually aligned the definitions, you can see the control arms, whether you're in France or the United States, median survival for ADT alone high volume is 32 months, and theirs was 35 months, pretty similar. And then if you look at the low volume, the groups did the same. Median survival is not reached, and basically if you look at the 4-year overall survival, it's about 60 to 70% in both groups. So they're similar on both fronts. So what have we learned? Early docetaxel works better in the US than France? No. The chartered investigators got lucky? I don't think so. Patients in prostate cancer differ in the United States and France, except maybe smoking, otherwise no. Therapies for castration-resistant prostate cancer subsequent to ADT and early docetaxel is key. Maybe. Cue the music, the cavalry comes in, stampede, thank God. So they had this multi-arm study with M0 and M1 and power to look at the subgroups. And basically, in one of the arms, hormonal therapy plus chemotherapy, there was a survival benefit for the M1 hormone-sensitive prostate cancer with a hazard ratio of 0.73, similar to what we saw in the chartered study. So Ian put together a lovely discussion at ASCO and talked about, did a meta-analysis. This is actually just going to Lancet Oncology, whereby a number of meta-analyses have been done, putting the cumulative data together, but I'm focusing on the M0 and the zoledronic acid. I'm guessing someone in the room may have been a reviewer for it, because it's there weren't that many people who would actually be qualified to review it, because it's quite dense. So here's the chartered study. This is GTUG 15, Stampede, both arms with and without the zoledronic acid, and a hazard ratio of 0.64 for time to progression, failure-free survival. So very consistent in the metric of controlling cancer, 15% absolute reduction in failure. And this is the survival data. Basically, a 0.77 hazard ratio. Chartered study is a bit divergent in how positive it was. The GTUG study was on the favour side of survival benefit. But in total, in the aggregate data, shows that there is a 10% absolute improvement in survival at 4 years. So fortunately, there is now some consistency in the data set. And Howard Scher put this slide up at ASCO this year and showed that the GTUG, the key difference, I think this actually sums it up nicely, GTUG accrued its patients before all these new therapies were approved for castration-resistant disease. So the green represents FDA approval. The orange represents European country approval, the EMA approval, of the cytotoxics and new hormonal therapies. And as you can see, the green and the orange actually overlap the accrual period for the Stampede and the Chartered study. So patients could accrue, progress, and get these therapies, whereas in GCHOG they accrued, progressed, and may not have accessed those therapies. And if we do tally this up, it does seem to hold out. So there was far more use of abiraterone and enzalutamide cabazitaxel in the ADT docetaxel arm, the first column, compared with the ADT docetaxel arm of the GTUG 15, with very few patients. The only real therapy the patients who got early docetaxel had was actually retreatment with docetaxel. So, is there any clinical data that would suggest that docetaxel is active in AR-negative disease, or disease that's not driven by a full-length androgen receptor? And then it is the docetaxel activity. And as you can see, there is a decline in PSA, whether you had this ARV7, this variant that has a poor prognosis of the androgen receptor in circulating tumour cells. So may not be as effective if you're ARV7 negative, but it is still active. Whereas if you use abiraterone and enzalutamide, these second-generation hormonal therapies, think of it as exemestane and the aromatase inhibitors, abiraterone and aromatase inhibitor equivalent, enzalutamide and potent ER inhibitor equivalent. You can see here that if you had the gold bars, or yellow in the projection, you're far less likely to benefit from AR inhibition in as much as your PSA didn't go down. And also, the further you are along in your process, so if you've got abiraterone followed by enzalutamide, or enzalutamide followed by abiraterone, the disease is more likely to be ARV7 positive, this variant, this constitutively active variant of the androgen receptor, presumably. So, speculation, exclamation mark, and you can say whatever you want if you've declared it a speculation, or maybe not. The disease that emerges with a rising PSA after early docetaxel is more AR dependent, and there's a greater benefit with AR targeted therapies. Again, speculation. So this survival curve, these two curves actually really do intrigue me. So these are just the time to progression, first one by rising PSA, blip in PSA, versus time to progression by evidence by radiographic or symptomatic worsening. And as you can see, it's basically parallel curves, like a tram track, if you would. 9 months progression to 16 months with a hazard ratio of 0.52. But we did track patients and ask them every 3 months when they came in, has the patient progressed clinically, not just by PSA? And as you can see, the curves actually diverged for these high-volume patients. So the question I have is, did attacking AR-negative clones early allow for subsequent CRPC therapies to be more effective? I don't know, but it's a speculation, it's a proposition. So I said I would start a conversation about hormone receptor-positive breast cancer. Again, this is speculation, but the question is, why was this study positive in prostate cancer and not breast cancer studies? And I was speaking with the Miles Brown, Eric Weiner, and Nancy Lin, a number of the breast cancer folk at Dana-Farber, as you do. Although we're amazingly silent, we actually do talk to each other. So breast cancer studies were hormonal therapy plus, or chemotherapy, not docetaxel, I should say, were hormonal therapy plus chemotherapy versus hormonal therapy alone. And this actually led to a propensity of putting patients with good prognosis, not visceral crisis process on, akin to the high volume, which actually would have events. So those studies did show a time to progression benefit for early chemotherapy, but not an overall survival benefit. So those studies may have had fewer events and behaved more like our low-volume charted patients, potentially. And also those studies were done when there were less therapies for disease that after your hormonal therapy. And there's also evidence that tamoxifen may not be the best hormonal therapy for ER antagonists. So there is a conversation that says if the studies were done now with hormones plus chemotherapy, with potent hormonal therapy, with the newer generation, in a high-volume patients, maybe the same findings would be recapitulated. This is again speculation, and I said I'm intrigued to see what the breast cancer gurus in the room would say about that. So, conclusion. Precision medicine in prostate cancer, how close are we? We have been implementing precision medicine for more than 70 years by targeting the androgen receptor, deploying therapies earlier when less heterogeneous. AI targeting is more effective in the adjuvant and the low-volume metastatic setting. That's how I think we will make advances. We cannot ignore clonal evolution, especially in patients with higher burden of disease and more advanced disease with greater heterogeneity. I think it's naive to think a magic bullet will be found for all patients. There is a major benefits with some magic bullets for some patients. The TOPARP study, which is in the New England Journal, using olaparib in patients who have DNA damage repair defects. Also, these anecdotes of PI3 kinase mutation PTEN loss patients who respond to PI3 kinase specific inhibition. If you want to find these patients, we have to biopsy their current disease. And I think we also need co-targeting for the majority of patients, as the Charted and the Stampede experience would tell us. We're attacking AR-positive and AR-negative clones early. So what is the chance of benefit with early docetaxel for metastatic hormone-sensitive disease? Young patient with high-volume disease, certain. Low-volume young patient, not sure. Although the Stampede people are saying give it to everyone, I think you need to sit and have a chat with the patient and talk about quality of life, and we will give longer-term follow-up data on that. Because if you're 75 years of age and you have low-volume disease and you have comorbidities, you may still be living for 5 years, but you may die of something else, and competing risk will actually dilute the survival signal. So I think it's not everyone with low-volume disease should get chemotherapy. But a 55-year-old who rolls in with 2 bony metastases, it's a conversation. Some patients say, give it to me, I want the benefit of the doubt and try everything. And others say, I don't want that stuff. Life expectancy of about 5 years. So if you have a 78-year-old who's chemo fit and has high-volume disease, I still think it warrants giving chemotherapy, even though because some men in their late 70s are destined to live beyond 85. So where are we now? What's the landscape of trials? Janssen is doing a study of ADT with or without their androgen receptor inhibitor, their enzalutamide equivalent called ARN-509, but only in low-volume disease. The SWOG is doing a study of a cousin of abiraterone called Alteranol, ATAC-700. Unicancer is doing a study of ADT abiraterone with or without local radiation therapy. And Janssen did a study of ADT plus or minus abiraterone in patients with high-volume disease. And Enzamet, this is a plug. Thank you, Canada, for opening this up. So this is a study that I have written in collaboration with Australia and UK, Dublin, Canada, and the Commonwealth of Massachusetts. Only Commonwealth empires are allowed to open this up. There's some shenanigans as to why we couldn't open up further in the United States, but that's by the by. So ADT plus or minus enzalutamide, and you get stratified by whether the physician felt docetaxel was a reasonable option for that patient. Early look at who's accruing. Median age is a little older than the Charted study, and about 50% of patients are getting docetaxel per physician and patient criteria. So it's actually a real-world analysis of who's actually getting it. Not everyone. So here's my take-home message. Let's move forward by moving backwards. We've developed all our therapies in castration-resistant disease. Using it metastatic hormone-sensitive, I think people will live longer, but we've got to do the studies. Using it in the micro-metastatic setting with our GU Radon colleagues, and we're doing the study of ADT plus or minus enzalutamide. Hopefully we will cure more patients. Acknowledgments. The ECOG team and the people who worked with me, the nurses, the statisticians, NCI and CTEP, Sanofi provided the drug and the grant for the study, and the US taxpayers. This was actually done with basically the US taxpayers' money, which is great, because I'm paying some taxes. And the DFCI clinical research team that did the abiraterone carboxantinib. So thank you everyone for your attention.